Thank you very much, Mr. Chairman, Co-Chairman, Frankie, my friend, and all colleagues in the room. I think this session is not about debate, what is better than another things. But the thing is, you know the options of the treatment, the advantages, the limitation. And this is one of the distraction osteogenesis is one of the options that you can use, and you can see that what we can make with it. Why I do distraction osteogenesis? Because it's predictable. Every time I do for, let's say, 20 years, I can say, always you have the bone. It's reliable, no limitation of the length, and you have adequate diameter. What is about the terminology? You can call distraction osteogenesis, calotaxis, callus distraction. This is the key. We distract the callus, the growing bone formation cells, or we can call this osteodistraction, because the new bone formation by biological process which induced by gradual mechanical distraction between surface of bone segment. That means around the cortical, around the circumferential. And we have types of, this is some terminology again. If you distract to length, we call unifocal. Don't be confused. But if you distract and also you go to the docking site like this, we have two sites or two focus to determine about the union. We call this bifocal, even though you do the one-point distraction. And if you have a very long segment defect, you can do from both sides and it meet at the center. We call this trifocal. Bifocal, for example, bone transportation, you can use pin system as Dr. Phiphobmongkol do. You can do ring, whatever in your hands, you can use it. It doesn't matter, and it depends on the stability that you need for this construction. You can do by nail to shorten it. This is this big defect. You can do along the nail. We call bone transportation over the nail. You can do bone transportation over the plate with ring or with unilateral frame, whatever you like. And even you are not comfortable with that, you can do bone transportation and plate or and nail, whatever. So you shorten the external fixated time. Now it comes to the basic principle. Distraction osteogenesis is not because we are old. This is, let's say, 60 years ago, and maybe 30, 40 years ago, it's come to the Western world from Russia. So it will be another 100 years, I would say. Because what? Because this is a nature. This is human physiology. It will be forever. But you have to learn how to do it. You have to learn. It's just only the frame construction. It is not that difficult, I would say. You can use unilateral frame or you can use ring. The 4 rules is 1, 2, 3, 4 is stability. You need a construction very stable because the biology you need. The cell has not to be damaged. Second, you have to preserve blood supply because you need the growing cells. And then you have to wait for a while, and then you have the rate about 1 millimeter per day, and the rhythm is just 3 to 4 times per day. Let's talk about the first 2 factors, stability and blood supply. This example of 35 years old male pedestrian hit by a car, open fracture both bone leg 3 years ago. He was rebride and plate, then infected, removed plate, rebride, X-fix. 6 months later, remove X-fix and cast. I don't know what the surgeon thought. And then non-union, for sure. Then he do X-fix and bone graft again. And it's non-united in X-fix, so he changed to something else like this. So this is 3 years of multiple operation. I think if he knows the concept, maybe better, he can manage it faster. Let's see, what's the problem? The problem is limb shortening for 4 centimeter. It's suitable for bifocal. The gap here, non-union side, is about 1 centimeter. And you have 2 pieces of drill bit left for you to manage. So, the first is the biology. The bride of the non-union. This is one of the biology. You have to get rid of infection. You have to remove the broken drills because some surrounding tissue around the drills may have some infected tissue. Corticotomy. This is very important. You have to preserve the blood supply. And you also have to lengthen it, right? Fibular osteotomy. So this is a technique that we use. This is preserved of the blood supply. You do periosteum preservation, drill bit, with multiple drill holes. You try to preserve the longitudinal connectivity of the periosteum from the proximal to distal. You just split it, and then you just connect drill bit with osteotome. Osteotome, thick but small osteotome. You can just corticotomy, medial, lateral, and then you break it with your thick osteotome. You see, this is a finish on the medial. You go to the lateral, and then you gently break it. You don't need to go to the posterior that much because you have some drill hole. And then you just use it to lever, and you can see the movement of this after you fix the frame. So we call this corticotomy, not osteotomy. So you preserve the blood supply, and this is the first rule. And the second rule, you have the stable construction like, as I said, unilateral ring. You can use, this is 2 pins with a ring, 2 pins at the middle segment, and 2 pins at the distal segment. I think we determine this stable. Then we may compress this for united because this is non-union. So first 2 requirements are achieved. Stability, biology, you agree? Now we have to wait how long? In general, for children, maybe 7 days. In the adult, maybe 10, 12 days. But in this multiple operation, bad scar soft tissue, you have to consider how to wait a little bit longer. So we wait a little bit longer. So the rate will be, instead of 1 millimeter per day, you can do 0.75 millimeter per day. And you can distract 3 times a day if you like. And you see, this is after distract 2 months. And as I said, this is very, very reliable. You will have it if you follow the rules. If you just know how to construct the frame, how to put the pin, you will have it always. And then 2 months we stop. As you know, we have to wait about 2 or 3 times of the distraction time to wait for the consolidation or distraction osteogenesis. So this is 4 months, not enough, but the quality of the bone is quite good. And this is 12 months, we have to maintain this. And you know, somebody said this is very cumbersome for the patient. Yes, a little bit, but it's not that pain, because if you know how to put the pin in the right place, you will have not that much pain. The patient can tolerate. This is 12 months, and this is the shortening. And then you get the length, okay? So that is, you can correct the defect and the lengthening at the same time. I will show the other 2 extreme cases. This is not just, I don't know how to do with this case. This is a tumor. The tumor surgeons resect it, and you know the tumor surgery, we have to resect it like infection. He puts this, processes, it's cost about 200,000 baht, I think. And this is just 2 months, 200,000 baht. He used only 2 months and it is infected. And this is what he has to do. He had to resect the infected bone and leave this big defect, a very short distal, and also something in the proximal. Fortunately, have something for me to do kind of bone transportation. And because we like to shorten the time of transportation, so we put this traction over the plate. It's good because you can control the alignment. You can put the plate, and then you can put the frame in. And then you can see we can transport 15 centimeter defect with this very short segment transport. So 2 weeks, you can see, because of the bad soft tissue around there with the tumor surgery, so what we can see is very slow, but it is, at that time we can expect that this is 4 months, and then this is 6 months, you arrive at the docking site. You have to wait how much? 2 or 3 times, that means year. Yes, that's why I put the plate, but unfortunately he has not infected, but the soft tissue is very bad, so it's exposed at the final stage because his plate is there. So what we can do, we remove the plate internally, but still put in the frame for another 1 year, 2 years, maybe not so good for her. So we put the RCP as an X-fix, and we can confirm to you by this study. We study with the engineer, and then we say, if you do temporary fixation with 1 RCP for the tibia, it's okay. You can use it. And the patient will be very comfortable. She likes to have this. This is 1.5 years after bone transportation. And then if you see consolidation, you can destabilize the frame gradually from follow-up to follow-up until you are sure. You can do at the OPD. And then you have this kind of very, very destabilization when the patient can walk full weight bearing. Actually, we can remove even faster if the docking side has been grafted, the patient denied because she loved this LCP X-Fix. I don't know why. She says she is very comfortable, don't like to have any operation. And this is 2 years. She can walk when we remove everything. So unlimited length. This is another picture to show you the series of her life. The last extreme case is just humorous, differ from some country neighboring. He had many operations in another country, and then with this X-Fix, with this cement spacer, with this infection, how about to solve this big defect? Fibular bone graft maybe, but I think this is reliable. You see, very reliable. And you have bone here. I don't know where is the last picture. Actually, now we list the docking side. And then it's because it's reliable. You can see this is unlimited. So the take-home message is you have to follow the principle 1, 2, 3, 4. Biology, stability, rate, and rhythm. And you have unlimited length. You have very good diameter. A long defect may need another combined fixation with plate or nail, or just conversion from the distraction to plate or nail. Thank you for your attention.